All right. Well, good. Thank you so much. I'm Steve Torch. You've heard from me before, and we're going to wrap up the day with some interesting discussions that will talk about some current work that we think has a lot of future implications, and then we'll wrap up with some discussion of this session on capacity building, and then George will finalize with some final thoughts for the day. So this session has two presenters. Darshak Sanghavi is the Director of Preventive and Population Health Models Group at the Centers for Medicare and Medicaid Innovation. I think most of you know about the innovative work that they're doing to try and transform our healthcare system as within the Centers for Medicare and Medicaid Services. And then we will be hearing from Rajiv Bhatia, who is the director of the Civic Engine, who has extraordinary experience in doing health impact assessments and similar work and helping to hopefully get to better health in all policies. And he has been doing some innovative new things, which I'm just beginning to learn about. So hopefully if he doesn't get a chance to talk about it during the session, we can hit on that in the discussion time. So Darshak, why don't we start with you? Thank you.
So I'll just start off and say, I was just joking with Alina in the back that I was actually got really stressed a couple of weeks ago. I was like, wow, you know, I work on preventive and population health models. I don't know if they know that the models we work on are not like the models we've been talking about all day today. We really work on payment models or experiments. So I just want to start off and say that. That's sort of what we do. But in that context, we actually do things that are based on the types of predictive models we've been talking about today. That's what I'll talk about. So so a model is a simplified representation of a real-world solution used to help answer a specific question. And I actually think about it this way. So it's like intelligence. Like, what is intelligence? And I think that a working definition is it's the ability to take complex things and make them simple. Conversely, stupidity is taking simple things and making them complex. And so our goal is to do more of the former and less of the latter when we make models. So having said all that, I watch a lot of reality TV, and I actually started to worry that I'm at the IOM people here, we're expecting a different kind of talk. And so what I wanted to emphasize is that one of the key things about modeling, the reason I'm talking about it in this way, is that we also at CMS and CMMI, one of the key things we have to do is we have to engage a variety of different stakeholders, patients, policymakers, and others, and talk in a way that actually explains what we do in a way that resonates, but also is true to the facts. And so that's sort of one approach here. So here's the thing. I don't know how many of you guys recognize the woman in the blue dress. Anybody know who she is? Yell out if you know who she is. Kelly Clarkson, yes. Totally. Awesome. So you can all read. Excellent. Good. So anybody know who the other guy is? Anyway, good. His name's yes. Yes. So Taylor Hicks. The reason I'm pointing this out is American Idol is a reality TV competition. The idea is to choose America's next big pop star. So Kelly Clarkson, one of the winners of season 1, huge pop star now, went on to make a lot of records, and there's predictive analytics there, right? The idea was that, yes, if America votes for who they think is the best on this show, she will go on to make lots of records that people will buy. That is in other words, there was an input, which was this show. There was a process, and then it was supposed to be predictive of the long-term outcome. The same thing is true, but Taylor Hicks got dropped by his record label right away, and he's faded into sort of nobody knows who he is anymore. So this is sort of one of the central things we talk about when we talk about healthcare and predictive modeling, which is that we all need to make decisions based on limited information and inputs, and whether or not those inputs are related to the outcome of interest, it can be quite questionable. So there are many parallels between reality TV, this way, and how we think about medical treatment. So in reality TV, you know, what's the ostensible goal? Is to identify the most talented recording artist or the most compatible couple if you watch The Bachelor or Bachelorette. But in drug trials, the thing is also important. It's like, how do you help a hyperactive first grader grow into a productive job-holding adult? How do you make sure that this particular therapy for somebody who has serious hip pain leads to them being able to walk and enjoying the activities they like to do? Right? That's what we care about. But what's the real goal? What are we actually measuring and what are we incentivizing? In reality TV, it's to like win ad dollars and television viewers, right? That's may or may not have relation to the outcome of interest. Similarly, with the drug trial, we find these sort of surrogate markers that are intermediate in the hopes they have some relation to the outcome of interest. So in a sense, this is not predictive modeling in the sense that we have tons and tons of variables, but this is the reality. We have limited information at time point 0, which we hope tells us about something that's going to happen at time point in the future. Why is this important? Because look at how it is that we currently incentivize predictive analytics in medical care now, and where are we at now in CMS and other payers, and where do we want to go? So let's say that, think about the clinical questions for which we currently use pay for performance, right? So we're moving towards value-based payments as a nation. We want to get to paying for performance. We don't think you should just pay the same for everybody. You want to pay more for people who do a good job. So the good job we care about is, do we stop heart attacks? Does that hyperactive first grader go see a pediatrician? Is he going to grow up into a responsible member of society? Does a perimenopausal woman remain free from hip fractures when she's elderly? All those things are exact. If you go to the doctor, that's what you want. But what is it that we actually measure for each of these? So for the first, we look at cholesterol levels, right? What's for the second thing? We look at a symptom checklist. I don't know if any of you have ever sort of dealt with pediatricians. They give you this checklist, you give it to the teacher, you fill it out yourself, and boom. That's the diagnosis of ADHD. And DEXA scans. So each of these are the surrogate endpoints that we incentivize. So through pay for performance, this is the decision we're currently making. That we believe that the model of care that we're delivering is that we will incentivize, meaning we will pay you to do a good job on cholesterol levels, potentially a symptom checklist if you're like, for example, in Arkansas, or if you do DEXA scans and sort of screen women in that way, with the hope that at some point will affect that long-term outcome. Is this a good strategy? Did we do this in a way which is truly thoughtful in getting us where we want to go with a value-based system? So if you think about any of you who are clinicians who've dealt with this, how are you incentivized to treat cholesterol? How are you incentivized to treat blood pressure? How are you incentivized to deal with smokers? Almost all of them are treated with process measures that are surrogates of surrogates. And so one thing I always think about is the predictive model. As I was watching some of the presentations this morning, it is really interesting how in actual clinical care, the amount of uncertainty is so vast. And these are randomized clinical trials that this evidence is built on. And even when you get 2 steps away from that outcome of ultimate interest, it's very difficult to know how strong that relation is. So this is some of the realities of how we think about this. So given all this uncertainty, how should CMS, how should a major payer deal with this in ways that enhance value, that actually use predictive modeling in smarter ways? So what's the problems with the surrogate endpoints? So let's think about that. So, if you getting back to reality TV, I don't know if any of you ever watched The Apprentice. That show is terrible. Why is it that winners of The Apprentice don't go on to run major clinical centers or the IOM? Because again, impressing the people on the show bears very little relationship to actually being good at the things that truly matter to run a major organization. And the other issue is that not only that, but the actual surrogate endpoint may actually be negatively related, right? I always think about this, like, when you're dating, like, there are certain signals that you send to your partner that are supposed to correlate with being like a good husband or wife or whatever, which may or may not really have any relation to that outcome of interest. So I think that this is the same way. And not only that, that if you excessively sort of set up all these expectations up front, that inevitably leads to romantic disappointment. So I think that, again, all these things have correlates in how we think about how do we incentivize care. So let me talk about, I want to get to the point you're probably like, what on earth does it have anything to do with CMMI? That we're getting there. So one of the major models we're talking about is how do we fix this? So one of the models that we hope will get, I've talked about this before, but we are hoping will be cleared formally for public release this month. It'll be the first model coming out of our group under this sort of new way of thinking about prevention, is called the Million Hearts Preventive Cardiac Model. So let's sort of get back. What is the thing we really care about? We want fewer heart attacks and strokes, right, as a society. We believe that is an important goal. How have we gotten there in the past? We've dealt with we set targets. If you look at PQRS, Blood pressure target, they tell you what to get to. They say, well, smoking, these are the surrogate endpoints. This is sort of cholesterol. If you're at this level, this is how low you need to go. How can we make that better? So let's give one example. Does actually targeting cholesterol levels to make them lower, is that a smart strategy? That's currently what we've done. It's actually kind of screwed up now because AHA tells you not to look at cholesterol, but CMS does. We're a little behind. And this is one of the reasons, is that look at all the ways in which when you just treat the surrogate endpoint, you run into trouble. I won't get into that too much. So here's a strategy. This is where we are going now. This is an iPhone app. It's the ASCV calculator. Hopefully it's familiar to some of you have seen it. You can download it. The bottom line is, today, the American Heart Association, American College of Cardiology, this is how we're supposed to do preventive cardiology. You go see your doctor. Your doctor is supposed to put in your risk factors, your age, sex, ethnicity, your HDL, blood, and what does it do? It spits out a 10-year risk of heart attack. Right here, so this is a hypothetical individual. The 10-year risk of heart attack in this person is 60%. That's a meaningful number. That is saying that if you're at that level, we can actually reduce that, and we want to get that down. So what we are doing is we are going to incentivize the reduction of that risk, not only at the individual level, but actually at the panel and practice level. In other words, you as a provider will be incentivized to reduce the aggregate cardiovascular risk of your practice. We don't tell you to reduce cholesterol. We don't tell you to get people to stop smoking. We don't tell you to treat their diabetes. The idea is that we incentivize the outcome of choice. And because this is a predictive analytic model, we know that this will correlate to the endpoint of interest long term. So this is one of the first times that we believe we can start to incentivize prevention in a whole different way using a predictive modeling algorithm. Cardiology is one in which the data is very, very strong. The randomized trials, everything that's underlying this are very good. We believe that this will then play some role in all the other types of predictive work that are being done today and open the door for thinking, can we pay for reduction of predicted risk in some way through these kinds of models? So that's the road that we're hoping to go on. I'll just say, anybody, just for fun, anybody, I'm running out of time, I think. Anybody know the #1 risk factor for cardiovascular disease? Just yell it out. Age, right. This is my son. He's 4. He is not at risk of heart disease, but how do we get him to walk? Again, this is like thinking about inputs and predictive modeling. It's how do you incentivize activity? We're hearing about people doing that in Georgia. There's a simple way to do that. You give people feedback, right? It's when you get that feedback, when we tell you what your cardiac risk is. This is my son. Actually, this is a pedometer. He wore this in Disney World. 30,000 steps, 11 miles in Disney World. This is at home in daycare. Just look at that. So that immediately, just that feedback made me change how we treated him. Similarly, when you get that kind of feedback, when you know that your cardiovascular risk panel profile is this much, these are your hot spotters, these are the ones you have to do, all of that is taken into account. You know where you're supposed to locate those efforts and then work with patients so you don't overtreat those that are low risk and you treat those that are high risk. Again, this is the kind of stuff that drives me bananas. Lipitor reduces your risk of 36%. Is that really meaningful, right? What's the key thing you need to know? Absolute risk, right? Yeah, you guys are predictive modelers. You know that. This is from the New England Journal. So I'll put out there, this is the kind of stuff we'd like people to start doing. We will incentivize the risk of 10-year risk calculators along with specific tools that will help physicians, providers talk to patients about their risk before and after. If you want to be on a statin, look, that's the risk that you'll reduce it to. I won't get into this in too much detail, but if people want to, we can talk about how this will jumpstart the conversation. It's not just about predictive risk, it's about then how do you talk to real people, give them the tools to make decisions on their own and motivate them, and we're going to do that in the context of a model test. Really quick, I'll just put 3 slides on this. Accountable health communities, this is our second model. This is where, in brief, we will incentivize large communities to address problems and invest resources. I've talked about this in other forums like this before at the last meeting, so I won't get into it too much. But in terms of predictive analytics, again, sort of because I'm not a super deep person, this is an iPad game I've been playing lately. It's called Plague. The object is to wipe out humanity. You choose your virus right there, and then you model everything you want to sort of wipe out the face. This is actually one of the biggest selling games, if any of you, you're looking at me like I'm crazy, but Like people like this game a lot. But the point is, this is predictive modeling, but we can also use it in a much more constructive way. And I don't have time to show this now, but recently Mark Gurovich is here. I met with some folks there, including Scott Braithwaite. This is the kind of stuff that we find useful. And there's a link here. If there's time, we can sort of go through this. But this actually is a predictive analytic model, essentially, where you as a health commissioner can go, if you're in New York or this is age in East Africa, you sort of put in, well, what's your level of evidence? How much money do you have? And it tells you what are the highest risk and biggest benefit interventions. So this actually gives you actionable, concrete steps you can take. And this is the kind of stuff we're also going to incentivize to one of our other models in the accountable health community. Again, running out of time, I'm happy to talk about that some more, but thanks.